Hello students, welcome to GT12 discussion of OMR subject, and we are going to start with the first question that was asked in GT12. The quality of X-ray is increased by quality. So we have studied about factors affecting the X-ray photons, correct? So we have learned about two terms. First is quality of X-ray photons, second one is quantity of X-ray photons. Okay, so first quality depends on the kVp. This we have studied, kilo voltage, correct? Kilo voltage meaning when you increase the potential difference between the anode and the cathode. Okay, that means you are energizing the electron cloud that is formed at the cathode. Okay, when you increase the potential difference, you are pushing this electron cloud from cathode to anode with highest amount of speed. Okay, when electrons go and hit the anode with highest amount of speed, it gives rise to the X-ray photons with good quality. Okay, so high energy X-ray photons we are going to get when we increase the kVp. Okay, next is quantity we have learned. Quantity meaning the number of electrons or number of electron cloud that is formed. Okay, more number of electron cloud that is formed at the cathode, more the number of X-ray photons that will be created. Okay, so quantity depends on the MA. MA is milliamperes, that is current, and the exposure time, which is seconds. So when you have it in the option MAS, go for MAS. Otherwise, if you have only MA, that is milliampere, in the option that is a current, then you can go for the milliamperes as your correct answer when asked about the quantity of the X-ray photons. Okay, so here what is your answer? Option number C, increased kVp will give us good quality of X-ray photons. All right. Moving on to the next question, an adolescent came to the clinic with a complaint of yellow-green discoloration of permanent teeth, having history of hospitalization for chronic disease when she was 4 to 5 years of her age. And this discoloration of teeth is due to which of the following condition? Okay, so you must have heard about the intrinsic discoloration. Okay, so when the child is at the pre-eruptive stage, okay, your permanent teeth are in the pre-eruptive stage at 4 to 5 years of age. So there is something called as pre-eruptive pre-eruptive causes for intrinsic discoloration. So when all the teeth are in developing stage, okay, that time if a child suffers from some chronic condition such as let's say there are some diseases that have potential to cause neonatal bilirubinemia. Bilirubinemia means increased bilirubin pigment. Okay, so when there is increased bilirubin, this bilirubin gets incorporated into the teeth, okay, the hard tissues, and that gives us this discoloration, which is intrinsic discoloration. Okay, so when the patient shows this yellow green discoloration of teeth, okay, this is due to increased bilirubin that gets incorporated into the teeth, the hard tissues of teeth, which are at developing stage. Okay, so this increased bilirubin can give us jaundice like yellow green tint. Okay, and this is called as chlordontia. Okay, now we have some other conditions which also uh, can cause this intrinsic discoloration, this yellow green discoloration. Okay, we have sickle cell anemia. I'll give you the list of the diseases, but here what should be our answer? Jaundice. Okay, yellow green discoloration of teeth. If patient have got history of jaundice during her developing or pre-eruptive stage of permanent teeth, then this discoloration can be caused due to the jaundice. Okay, so this is our answer. And there are some other conditions that can also cause the yellow green discoloration. Okay, that is sickle cell anemia. We have thalassemia. Okay, then we have hemolytic disease of newborn due to Rh factor. Okay, we have bile duct obstruction that can also cause the yellow green tint or discoloration. Okay, so we have reddish brown discoloration also. Reddish brown discoloration also. Okay, this happens in which condition? This happens in congenital congenital erythropoietic porphyria. Porphyria. This is also called as Gunther's disease. So if they ask you reddish brown pigmentation, it can be caused due to this condition called as Gunther's disease. And what happens is this is basically autosomal condition, autosomal recessive condition. Okay, so this porphyrin pigment which is there, okay, there will be disturbance in the porphyrin metabolism, and the porphyrin has got affinity for calcium phosphate. Okay, so when teeth are in the developing stage, what happens is this has got affinity towards calcium phosphate, so this porphyrin pigment gets incorporated into the hard tissues of teeth. That can cause the discoloration. Okay. Okay. So we have porphyrin pigment which is incorporated into the teeth, and that can cause reddish brown pigmentation, and this is called as erythrodontia. Erythrodontia. Okay. The yellow green pigmentation is called chlorodontia. This is called as erythrodontia. Okay. Now we have the next question. Okay. Now this is 20% KOH mount used for rapid evaluation of Candida fungus. This can cause A. Staining of Candida hyphae, B. Destruction of hyphal tissue, C. Dissolution of underlying epithelial tissue, D. Fluorescence. Okay, so you should first know what is the use of 20% KOH. Okay, so this 20% KOH mount is used for let's say rapid detection of this fungi. Okay, rapid detection of fungi. So when you suspect any candidiasis infection in the oral cavity, you scrape it off, you put it on the slide, you put 20% KOH on it. Okay, this 20% KOH will dissolve all the keratin and the epithelial cells. Epithelial cells. So these are basically tissue debris. Okay, tissue debris. So this KOH basically clears out the tissue debris, and the fungal elements may what all are included. We have hyphal tissue. Okay, we have a pseudohyphae, we have spores. Okay, so all the fungal elements which are there, they remain intact. Okay, they remain intact. This KOH will dissolve all the background noise which is there. Background noise meaning all the tissue debris, all the epithelial cells, keratin. It will dissolve all the keratin, and this fungal elements remains intact. Okay, so that it is very easy to visualize this fungal elements under the microscope. So this is the use of 20% KOH. So we'll go by the option. Staining of Candida hyphae. It does not stain the Candida hyphae. Okay, it only clears the background. Okay, tissue debris. Destruction of hyphal tissue. No, it does not cause destruction, but it makes the fungal elements remain intact by dissolving the tissue debris. C option, yes, it causes dissolution of underlying epithelial tissue. It does not cause any fluorescence. It does not cause any fluorescence. Okay. Now, the next question that we have is maximum chance of sialolithiasis occur. Sialolithiasis is silolith, calcification, or the salivary stone. Salivary stone. Okay, the maximum chance of sialolithiasis is in the submandibular duct, which is a Wharton's duct. And what are the reason of Wharton's duct? The location of it, the tortuous course of the Wharton's duct, the composition of the saliva, composition of saliva, and the location of the orifice of this Wharton duct, okay, is at higher level than the gland, okay, and due to gravity, all the content gets pulled in inside the duct, okay, and there is higher chance of formation of this salivary stone inside this Wharton's duct or submandibular duct. Okay, so this is easy question, correct? Question number 5. During taking radiograph of upper first molar, its buccal root appeared distal to lingual root. What should be the angulation of cone? So, very easy, apply SLOB rule here. Okay. So, they have told us that your first premolar, let's draw first premolar. Okay. So, this is the buccal root. Let's say this is the buccal root. This is the lingual root. This is the lingual root. Okay. So they have told us the buccal root appears more distal than the lingual root. Okay. Buccal root appears more distal than the lingual root. Okay. So this is, let's assume that this is the second radiograph that we have taken. Second radiograph or second IOPA. Okay. So first IOPA में you get to see this roots like this. This roots like this. Okay. Buccal root and the lingual root. Now we want to let's say assist the roots, that is buccal and lingual roots. So what we are going to do, we are going to shift our tube. Okay, this radiograph, this IOPA, you will take it with a normal angulation, all the normal angulation. Okay, okay. Now this IOPA, we will take it just by shifting the tube. Okay. Now they have already given the condition here. Your buccal root is appearing little distal than the lingual root. That means your tube shift should be on mesial side. Tube shift should be on mesial side. In this scenario only, you will get to see the buccal root more distal than the lingual root, because we follow SLOB rule. Same side lingual, opposite side buccal. Okay, that means if your root is moving to the opposite side of the tube shift, that means your root is located buccally. Your root is located buccally. Not only root, we follow this SLOB rule for foreign material, foreign objects. If you are suspecting impacted tooth, supernumerary tooth, okay. So this rule we have to apply it, and here the tube shift should be on the mesial side. That time you will get to see the buccal root moving distally. Okay, so what should be your answer? Cone head were more mesial. Option number B is the correct answer over here. Draw the whole, you can say, scenario, whatever they have given. Not only regarding this first premolar, if they ask you about impacted supernumerary tooth or any foreign object that or foreign structure that you suspect. Okay, draw the whole scenario and apply SLOB rule here. You will be able to answer this kind of question very easily. Okay, all right. Now, moving on to the sixth question, what is Greenspan's lesion? Very easy. Hairy leukoplakia is the Greenspan's lesion. And we have one more Greenspan term, which is Greenspan syndrome. What is Greenspan syndrome? Greenspan syndrome is association of lichen planus with hypertension and diabetes. So Greenspan syndrome is option number C. Greenspan's lesion is option number A. Okay, very easy. Question number 7. Alarm clock headache. Alarm clock headache are seen in alarm clock, meaning this attack at the same time of the day. Same time of the day. Okay, so today if you are having this headache at 4 o'clock, tomorrow you will have it at 4 o'clock. Okay, that is called as alarm clock headache. And alarm clock headache is nothing but sphenopalatine neuralgia. Okay, the other name for it is cluster headache. Cluster headache. Okay, so patient will have this throbbing pain, and in association with the rhinorrhea, okay, lacrimation, flushing, and swelling of the face, and patient will have this unilateral pain around the eye, okay, and patient will get the attack at the same time of the day. Okay, so this is about cluster headache, which is also called as sphenopalatine neuralgia, which is also called as alarm clock headaches. Okay, so let's move on to the eighth question. Okay, this McGregor Trampnell lines are seen on. Okay, so these are not seen on, but these lines are traced on which of this view? This traced on PA Waters view. PA Waters view. Okay. Basically, these are imaginary lines. So we have McGregor, Campbell lines, and the fifth line is Trampnell line. Okay, so these lines we trace it on the Waters view, and this basically assesses the fractures of middle third of the face. Okay, so we trace it like this. This is the first line, this is second line, this is third line, and this is fourth line. Fifth line joins this angle of mandible from right crossing midline, and this joins the angle of mandible on other side. This is the fifth line, which is a Trampnell line. Trampnell line. Okay, so this we draw it or trace it to assess the middle third fractures of face, and this we trace it on the PA Waters view. PA Waters view. The first line, if you look at the first line, it is joining zygomatico frontal suture. It is tracing the superior edge of the orbit. This is the orbit, superior edge of the orbit, and it is joining the other side of the zygomatico-frontal suture. Okay, the second line will be tracing the zygomatic arch. This is the zygomatic arch, zygomatic bone, and then the inferior border of orbit crossing the bridge of the nose, joining the other side of the same bone. Okay, third line, it connects the condyle. It connects the condyle, then coronoid process, then the maxillary antrum, the floor of the maxillary antrum, and joining the opposite side. The fourth line will be connecting the mandibular ramus. Okay, this is the ramus. This is the ramus of mandible. Ramus placing the occlusal plane of the teeth and joining the other side of the ramus. Okay, so in this way, we are going to trace the PA Waters view, the lines, on it, and then we can assess the middle third fractures of face. Okay, you will learn this in surgery, oral surgery. Okay, but just to have a basic idea, these lines are related to to assess the fractures of middle third of face. This you should know. Okay. Moving on to question number 9. Which of the following is also called a Darling's disease? Very easy, very factual question. Histoplasmosis is called as Darling's disease. Okay, histoplasmosis. Uh, then we have the 10th question: which cell organelle is least affected by the radiotherapy? Okay, if we talk about the radiotherapy, it can cause radiation induced cell death. Radiation induced cell death. Okay, so the main target of this radiation is the genetic material. And which is the genetic material? It is DNA. It is DNA. Okay. DNA inside the nucleus. So nucleus is also affected, of course. Talking about mitochondria, when it affects mitochondria, it disrupts the metabolism, cellular metabolism, and it disrupts the apoptosis pathway. Okay, if we talk about cell membrane, this is the structural component. Okay, structural component. Basically, the radiation targets the genetic material, that is DNA, which is inside the nucleus. Okay, and this, rather than the structural component, it mainly targets the DNA and the nucleus. Okay, so the cell membrane is least affected by the by the radiation or radiotherapy. Okay, so cell membrane basically made up of a lipid membranes, correct? Lipid membranes. Okay, so they have got some resistance as compared to DNA, as compared to DNA. So cell membrane is the least affected, you can say, the component by the radiation. Okay, easy. Next question, 11th question. At 65 kVp and 10 mA, that is milliampere, target film distance of 8 inches, exposure time is half a second. Under same situation, the exposure time is at 16 inches. They had asked about exposure time at 16 inches. First, you can just write down this parameters which are already given. Okay, then we need to we need to find some relation between these exposure time, the target film distance, or the kilovoltage, milliamperes, everything. So we know the relation of the density of the film depends on the kVp, or directly proportional to kVp, ma, and the exposure time, correct? And it is inversely proportional to target film distance, the square of target film distance, correct? Now, if we keep the kVp and ma constant, okay, we need to draw relation between this distance and the exposure time, because these are the given parameters here. Okay, so at same condition they had asked, so this kilovoltage and ma will remain constant. Okay, so we can draw the uh, let's say relationship like this. The exposure time, if we take this distance, square of distance over here, this will be the relationship between exposure time and the distance, target film distance. Okay, so we can just write down the formula here. D1 upon D2 is equal to square of D1 upon D2 is equal to T1 upon T2. Okay, so D1, D2, just put all the values in this and just solve this mathematical equation. Just solve this mathematical equation. You will get T2 as 2 seconds. You will get T2 as 2 seconds. So we had asked the exposure time at 16 inches will be 2 seconds. You just have to apply this formula put all the parameters which are given and then draw the correct answer. Okay, easy. Moving on to the next question. Which of the following statement concerning X-ray radiation to the oral regions are correct? Okay, so we need to mark the correct statements, or in the options they had given which all are the correct statements. So we'll go option by option. Although X-ray irradiation affects skin, a characteristic produces no changes in the oral mucous membrane. Is this statement true? Not at all. Oral mucous membrane is highly sensitive to the radiation because the basal layer, basal or basement membrane, basal layer of the OMM is the highly sensitive, because this is highly dividing layer or highly dividing cells. So this is highly radiosensitive. So this is wrong statement. X-ray radiation can result in damage to salivary gland cells, resulting in atrophy and xerostomia. Yes, when the radiation affects the salivary gland, it can cause the xerostomia, that is dry mouth, because there is atrophy of the salivary acinar cells that happens due to the radiation. Okay, so this is the correct statement. X-ray radiation can result in permanent damage to vascular bed of the bone, leading to poor healing following injury infection. This is called as osteoradionecrosis, correct? Osteoradionecrosis. So this is the correct statement, of course. Radiation affects the vascular supply, more commonly seen in the mandible, because mandible has got less blood supply than compared to the maxilla. So when addition to this, when the radiation affects mandible, it all causes poor vascular supply, and if you are causing any trauma or injury to the mandible, it can worsen the case and cause osteoradionecrosis. Okay, then X-ray radiation has not been shown to have any effect on developing teeth. This is wrong statement. It shows effects on developing teeth. It all depends on whether the exposure has happened before calcification or after calcification. If it occurs before calcification, it can destroy the tooth board. If it occurs after calcification, it affects the development of roots or the general development of the tooth. Okay, so only of statement second and third, that is B and C, only statement B and C is the correct statement. Okay, so this is question number 12. Question number 13, Mach band effect. Mach band effect. Mach band effect is seen due to, so I'll just show you the picture. uh, if you look at the tooth, okay, we have different density of the tissues, starting from enamel, then we have dentine, then we have the pulp tissue inside this. Correct? Pulp tissue inside this. Okay. So this difference in densities, you will clearly see it on the radiograph. Okay. Difference in densities. Difference in densities, due to which on the radiograph you see shades of gray. So this is highly radiopaque, this is little lesser in density as compared to enamel. Dentine is lesser in density than enamel, so it appears little um, um, uh, lighter than the enamel. Okay, so we have different shades of gray, correct? Different shades of gray on the radiograph that you can see, correct? So what is Mach band effect? Mach band effect is just optical illusion. When you keep shades of gray just adjacent to each other, you will see the line, faint gray line separating these two shades of gray. Okay, that is a Mach band effect. It is just an optical illusion. Okay, so it, this optical illusion just exaggerates, okay, exaggerates the contrast between the edges of slightly different shades of gray, correct? That is called as Mach band effect. Okay, so this Mach band, what is the significance or importance of Mach band effect is, sometimes what happens is this Mach band effect can give us false positive diagnosis for caries. Okay, false positive diagnosis for caries. So during evaluating the radiograph for evidence of decay, you need to be very careful whether it is a Mac-band defect or it is a decay. Okay, so here if you compare this and this, okay, here you can easily see this caries. Okay, caries, that is radiolucency, ill-defined radiolucency. Here you can see this faint gray line which is separating the two shades of gray. Okay, that is called as Mach band effect. But here you can easily see the decay or radiolucency, which is nothing but a caries. So while evaluating caries, you need to be very careful whether it is a Mach band defect or a carious lesion. Okay, that is all the significance of the Mach band defect. Not um, uh, commonly asked, but you should have a basic idea about it. Okay, so what is the Mach band effect here? This is just optical illusion due to presence of adjacent light and dark areas on the radiograph. Okay, this is a Mach band effect. All right. The last question is Salmon patch. This is asked in last year's PYQ. Okay, this is the last year's PYQ. Salmon patch is a form of okay, A, dermatitis, B, allergy, C, sarcoidosis, D, vascular malformation. I'll tell you the answer is vascular malformation. What is this vascular malformation? Basically, vascular malformation can be due to the abnormalities in the vessels or vessel structure. It could be in the arteries, it could be in the veins, it could be in the capillaries. Okay, so we have capillary malformation, we have got types of capillary malformation. Okay, so we have nevus simplex, and second one is nevus flammeus. Nevus flammeus. This is also called as port wine stain. Port wine stain. Okay. What is nevus simplex? This is called as salmon patch. This is called as salmon patch. So you will see in 40% of newborn, 40% newborn, it is very common, very common. You will see flat pink patches, flat pink patches, okay, either on forehead, either on nape of the neck, okay. If you see it on the forehead, it is called as angel's kiss, angel's kiss. If you see it on the nape of the neck, it is called as stroke bite, forehead and nape of the neck. Okay, so this is capillary malformation which manifests as a flat pink patches, that is called as nevus simplex. Okay, now nevus flammeus is a port wine stain. Okay, so this is basically a large flat patch of purple or dark red in color. Port wine stain you must have seen in Sturge-Weber syndrome, correct? Sturge-Weber syndrome. So this is a large flat patch of purple or dark red in color. Okay, face is commonly involved as compared to other body area. uh, Face is more commonly involved, and you can see it on one side, and you can see sharp midline cutoff means it will not cross the midline. On unilaterally you will see large flat purple or dark red flat patch. Okay, that is a port wine stain, which is also called as nevus flammeus. And nevus simplex you will see it on newborn, 40% of newborn, very common. And you can see it on forehead or nape of the neck. Nevus simplex is called as salmon patch. Okay, and nevus flammeus is called as port wine stain. So these are types of capillary malformation that you should have a basic idea about. Okay, so this was 14th question. If you have got any doubt, you can just post it in the Telegram group. And all the best to all of you for your next test. Okay.